This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
So I'd like to welcome you to the Rady Children's Hospital San Diego UCSD Department of Pediatrics Grand Rounds. This is also the 16th annual LeNoir Memorial Lectureship. This lectureship was established by Dr. Robert Hamburger, who I guess was not able to make it today. He set this up in 1999, and we have it coincide somewhat closely to the Martin Luther King holiday, which is coming up in a couple weeks. For those of you who don't know Dr. Hamburger, he's sort of an icon here at UCSD. He's a UCSD Emeritus Professor of Pediatrics. He's also on staff here at Rady Children's. And he came to UCSD from Yale in 1960 to join the newly created Department of Biology. He was one of the founding fathers of the medical school in 1965. And then he served as assistant dean for the first 8 years. And then he served as my predecessor, the chief of Division of Pediatric Immunology and Allergy. And he was there for over 20 years and actually trained dozens of allergists all around the country, including Dr. LeNoir. So the lectureship was formed in memory of the wife of one of UCSD's first allergy immunology fellows, Dr. Michael LeNoir. Dr. LeNoir's wife, Andrea, died during a severe asthma attack at a young age. And then after completing fellowship, Dr. LeNoir dedicated his life to helping patients with asthma, particularly patients with asthma in the inner city. He was actually the first speaker in 1999 of this lectureship, and he spoke on inner city asthma. Since that time, the lecture has sort of maintained these two themes. The first theme is health disparities, and this has had sort of a broad interpretation, but we focus a lot on health disparities, and also particularly allergy immunology disease, particularly prevention, diagnosis, and treatment. And we've had an amazing group of speakers since 1999 from all over the place, but also some really great talent locally. And really, with the exception of the one talk in 2011, it's been a great group of talks. And I expect this year to be a continuation of that tradition. So our very special speaker this year is Dr. Anthony Eiton, who since 2009 has been the Vice President of Healthy Communities in the California Endowment. And I'll tell you a little bit more about the California Endowment in his talk. Prior to this, he served as the Alameda County Public Health Department Director. A little bit about him: he attended Hopkins as a medical student and did his internal medicine and preventative medicine training at Cornell, Yale, and then public health at Berkeley. He also has a law degree as well as public health at Berkeley. He's received numerous awards in the field of public health services. He's been on numerous state and national boards. He's also presented dozens of national and international lectures. His areas of focus, and he'll tell you some about that over the years, have been on prevention of communicable diseases, reducing burden of obesity and chronic disease, and also preparing for biologic terrorism. But his primary interest is the health of disadvantaged population, and he'll talk about that today. Please welcome Dr. Anthony Eiton.
Well, good morning. It's always a pleasure to be at a grand round. This one's a little bit unusual because not everybody's sitting in the back row, which I suspect is probably evidence of a great deal of interest in the topic, and I hope I can live up to that. I want to thank Dr. Hoffman for inviting me. I always love any excuse to come down to San Diego. I was in Washington yesterday, actually at the White House, because the president was announcing a big award for Los Angeles. And there's this concept of essentially creating comprehensive multi-sectoral interventions in communities to try to improve the opportunity structures for low-income people. And the president has created this notion of promise neighborhoods or promise zones based on this concept that developed in Harlem called the Harlem Children's Zone. And so yesterday the president was announcing the first cluster of promise neighborhoods around the country, and Los Angeles is going to be one of them, and we're very pleased with that because at the California Endowment, we're actually sponsoring 14 neighborhoods around the state with a similar kind of notion that if we can bring people together, organize them, bring the systems together, sometimes I refer to them as the butcher, the baker, the candlestick maker, we can actually improve, using the same resources, we can actually improve the outcomes for low-income families and children. In San Diego, we have a site in City Heights, and the manager of that site is Stephen Eldred, who's here today. Steve, you just stand up for a second so people can see you. Some of you know Steve because he's been in San Diego since I think the Cretaceous period. And he used to work at the county health department managing HIV AIDS, so he's been through those wars as well. Typically after some of these presentations, there are either medical students or residents who say, you know, I'm interested in this work. How can I get involved? And I just point at the local program manager. That's why I had Steve stand up, because Steve is the access point for the work here. So I'm just going to get started. Okay, so as Hal mentioned, I had the either good fortune or misfortune of also going to law school, depending on your perspective. And one of the things you learn in law school is always state your conclusions up front, because unlike a lot of other endeavors, in law you're frequently interrupted. And so if you're presenting a case in front of a court or whatever, a judge can interrupt you, the other attorney can interrupt you, and if you don't state your conclusion, then argue back from your conclusion, frequently you never get to your conclusion. So I've learned to state my conclusions up front. It's also a very good way, by the way, for those of you who do any media work, to construct a soundbite. If you really want to get kind of a pithy point across, just state your conclusion and then start working back from your conclusion, because typically reporters they're easily bored, and so they want to know exactly what it is that you're trying to say, and they'll run with that. That'll typically be the headline in their article. So here are my conclusions. One is that health is small p political. And what that means is that one definition of politics is the struggle over the allocation of scarce and precious social goods. And in California and across the United States, we have many communities that don't actively participate in that struggle. And when we're talking about scarce and precious social goods, we're talking about not esoteric things. We're talking about things like a grocery store or a park. And in many of our communities in this state, you can very much easily live in a neighborhood where you cannot find healthy food, where you cannot find a place to exercise. And as a physician, I got tired over my career of trying to encourage people to do things that they couldn't realistically do. So part of being responsible, I think, in medicine is actually helping communities get access to those things that we all know that they need to be healthy. And so the way that we get access to those things in this society is through a political process. It's through a participatory process where essentially decisions are made and resources are allocated. And the extent to which people participate in those processes correlates with the extent to which they get an equitable share of those health protective resources. So health is political. Another conclusion is that your zip code probably matters more than your genetic code. That's shocking to some people, and I'll try to prove it to you. You can believe me or not believe me, but if you don't believe me, you're probably not looking at the evidence. I was the Alameda County Health Director and Health Officer, and one of the jobs of the health officer is to be the registrar of all births and deaths, which is a wonderful job. I used to say to people in Alameda County, you know what, you're not dead until I say you're dead, because I have to sign your death certificate. And every one of you is going to have one of these things. And so your job is really to manage the data on your death certificate. Because on a death certificate, we can tell what you died of, we can tell what your age was when you died, we can tell what your race, ethnicity was, and we can tell where you lived. And those four pieces of data can actually, in an aggregate database, can tell you a lot about the distribution and patterns of death in a community. And there's a lot of meaning in those patterns that we frequently overlook. And that's what I'm going to actually help you understand today. I'm also going to show you a very simple framework because I come from an academic background and we can't say anything without putting it into a framework or a model. This thing is called the BARHI framework, which stands for the Bay Area Regional Health Inequities Initiative, which is a mouthful, but it's actually quite a simple framework, which I'm going to walk you through. I'm also going to talk to you about a piece of that framework which talks about power and the fact that one of the critical roles, particularly in public health, but it's also relevant to clinical medicine, is to empower people to participate in decision making, to empower your patients to participate in the decision making that happens in the clinical setting, to actually allow them to recognize the assets that they have to help themselves as well as others that are similarly situated. That's a critical piece of trying to improve health. Okay, so first thing I want to talk about is place. I said your zip code matters more than your genetic code. What did I mean by that? Well, this is where I grew up. I grew up in a beautiful city in another country. This is Montreal, Canada, in the 1960s and 70s, and was very privileged to have grown up in that place. It's not only a gorgeous city that has universal health care. I went to McGill University basically for free. I got paid to go there. And universal dental care, universal child care, wonderful parks, and a whole host of community amenities that are supported by sort of a collective enterprise known as the government. This is the view from Mount Royal. Montreal is actually it's an old volcano in the middle of the St. Lawrence River. So it's a mountain. It's actually kind of a hill, which overlooks the St. Lawrence on either side. You can have a panoramic view from Mount Royal, and this is overlooking McGill University. And then I ended up going to Baltimore, Maryland for medical school at the ripe old age of 22. And this is what I encountered. This is literally, in the immediate neighborhood of Johns Hopkins Medical School. And I had no clue what I was looking at. I literally had no clue that there was an upperclassman driving me around East Baltimore. And, he saw my mouth was hanging open, my eyes were bugged out. And he said, "What's wrong?" And I said, "When was there a war here?" And he literally looked around at me, and, kind of like, "You idiot." And he said, "What did you expect? It's the inner city." And I thought, what did I expect? You mean you expect this? And you've got a name for it? I mean, you've just described something that's a phenomenon of America. And it's something that Americans expect. And I, thankfully, was not at the point in my life where I expected to see this. And the rest of my career has been trying to explain to myself how people can be healthy in this kind of environment. And I look at young kids growing up in those neighborhoods, and I recognize that those kids, for all, intents, could have been me. And the question, I think, for us in health, and as a society in general, is what do we owe these kids? What's our responsibility in terms of creating an environment, a zip code, a neighborhood, a context in which people can grow up to be healthy? And is this natural? I mean, is this just the way sort of cities evolve and some people win, some people lose, as certain people have suggested to me? It's just, that's the sort of the nature of the game. Or is this a set of policy choices or the absence of sensible policy in the face of abject need that has created these conditions? And if so, what are the impacts of that on the health of the patients that come to see you day in, day out in the clinical setting? Okay, so this was my trip from Montreal down to Baltimore, Maryland. That's Johns Hopkins Medical School. And then I went back to give a lecture at Johns Hopkins last year, and I decided I'm going to tour East Baltimore again with my camera and see what I found. This is what I found. This is 2013 in East Baltimore. And this is where people live. Okay, so I ended up in the Bay Area after medical school and training. And just for those of you who don't know what the Bay Area looks like, and I hope that's not too many of you because it's not that far. This is San Francisco, and this is Alameda County. It's a big county that's shaped like a boot that's very much interested in crushing San Francisco. And I'm showing you this because I'm going to show you a couple pictures in a sense. So I told you about death certificates. You can take death certificates. When I got to Alameda County, I was very excited about the fact that I owned all these death certificates. And I'm a data nerd. I just love numbers. And so I said to my epidemiologist, I said, how many of these things do we have? And they said, well, we have them going back to the late 1940s. And I was like, you're kidding me. I just got it. Let's put them into a database. And they looked at me like, really? And I said, yeah. And so we ended up constructing a database with roughly 500,000 death certificates in it, looking at Alameda County from basically the present going back into, the data starts getting sketchy kind of in the 1950s. So we have solid data into sort of like the early 1960s. And one of the things you can construct with this data is a neighborhood map looking at life expectancy by neighborhood. Very easy to do. In fact, I'm working with San Diego, the department now, to do the same thing in San Diego. And you can calculate on average the age to which people live in various different neighborhoods. And when you do that in Alameda County, and we've just sort of arbitrarily stratified these life expectancies into 3 groups, the green areas where people live relatively long, over 80 years, are distributed kind of throughout Alameda County in certain areas. And there are yellow areas where people live on average between 74 and 80 years. And then there are red areas where people live on average less than 74 years. And so when we first did this, I said to the epidemiologist, I want to map this. And they said, you know, you're wasting your time. And even worse, you're wasting our time because this is going to look like a Christmas tree. Death is randomly distributed. There's no pattern to it. You're not going to see anything. I said, well, I've been to East Baltimore. I just can't believe that there aren't sort of higher levels of death there. Let's just look at this. And I'll never forget the epidemiologist who came running into my office with this map saying, you won't believe this. I'm like, I think I probably will. And they showed me this map, and we saw that we have these death zones in Alameda County where people, you know, on average live roughly 10 to 15 years, in some cases over 20 years, less long than people in other parts of the county or even other parts of the same city. So we thought, well, this is frightening. We controlled for things like nursing homes and that kind of thing. And it actually doesn't make a difference. And I can show you some data later if you're really interested. I started showing these maps around, and people started saying to me, oh my God, I never want to live in Alameda County. And I said, well, it's not just Alameda County. So we went up to Seattle, King County. We did the same analysis with the King County Health Department, and they found the same phenomenon. I had to go back to Baltimore because I just needed to know. This is Baltimore, Maryland, where you have neighborhoods with life expectancies of as low as 58 years on average. This is an updated map that was in the Baltimore Sun not too long ago looking at the same thing. This is LA. This is Cuyahoga County, Cleveland, which I really enjoyed doing it because they had one of the biggest gaps I'd ever seen. They have a neighborhood in East Cleveland called Huff with a life expectancy of 64 years. And just down the street in Lyndhurst, they have one that approaches 90 years. And right now, our explanation for this difference is lack of access to health care and bad behaviors. That's our narrative for why there are these huge differences in life expectancies between neighborhoods. And so we act like we have to go into Huff with more medical care and more brochures telling people how to live their lives. And that's the medical model approach to trying to solve these problems. This is something that the Robert Wood Johnson Foundation did looking at the Philadelphia transit system and predicting how long you live based on which stop you get off on the train. So the other thing you can do with this data, and as I said, I'm a total junkie, so you can go into the census, and at each neighborhood level, you can find the poverty level. So for each census tract, there are about 150 in Alameda County, you can have life expectancy and a poverty level, and then you can correlate them in a simple bivariate correlation here with the left side of the graph basically showing relatively wealthy neighborhoods, and as you move right, you're going into poorer neighborhoods, and as you move right, life gets shorter. And you can actually calculate essentially a regression line on this and predict how long people will live based on their address. And you'll be right most of the time, which is scary. In an ideal world, this would be a completely flat line. What neighborhood you lived in wouldn't predict how long you lived. But we don't live in an ideal world. Now, some of you are thinking, I know, that this is about homicide and HIV, AIDS, and things that are basically just social problems. And let me disabuse you of that belief. What's driving this difference is chronic disease. This is heart disease, this is cancer, this is stroke. These are the things that are killing all people in Alameda County. They're just killing people in low-income neighborhoods earlier and making them sicker in their lives. We subtracted out homicides, HIV, AIDS, infant mortality from these calculations, and it made very little difference. That's only about 5% of the difference. 95% of the difference is chronic disease. Things that we ostensibly know how to treat and prevent. We have people in Alameda County that live on average in neighborhoods with average life expectancies in the mid-80s and some with average life expectancies in the mid to upper 60s. Just on a world life expectancy map, that correlates with some of the highest life expectancy countries in the world, as well as places like, I always have to take off my glasses for this, Uzbekistan, Iraq, Bhutan, Bolivia, Kyrgyzstan, North Korea, Tajikistan, Laos, all in Alameda County. We have the socio-ecological equivalent of those places in Alameda County, and you have them here in San Diego County. This is the Bay Area as a whole, looking at about 6.5 million lives. This is the correlation here. This is the state of California as a whole with the regression line. In the Bay Area, you can actually calculate the slope of that line and tell that every additional $12,500 in household income buys you a year of life. That's the cost of life in the San Francisco Bay Area. And I tell people to use that number when they're negotiating their pay. Just, you know, can you imagine talking to your boss? Boss, I need a couple years. I mean, I need to get past seeing my kids out of college. I need to see that, you know, that lazy one get married. And the boss is going to say back to you, you know, Tony, I'm seeing 6 months for you, you know. Your performance is, you know, in Baltimore, by the way, you can get 3 years of life for $10,000. So if you're looking for a deal on life, Baltimore's the place to go. And some people, probably the nerds in the room, are saying, you know, well, that's a correlation. That doesn't prove cause and effect. And I'm right. Calm down, nerds. You're right. But what we actually also happen to have in Alameda County is a longitudinal cohort study that's looked at 7,000 Alameda County residents from 1965 to the present. It's still ongoing. It's published about 200 studies from that cohort, one of which reveals that those Alameda County residents with household incomes, one standard deviation above the mean, were 25% less likely to die prematurely. If you're one standard deviation below the mean, you're 35% more likely to die prematurely, which correlates almost exactly to our regression line. So this is my data. If you don't believe me, show me yours. Okay, so we've gone around the country in various different places and looked at these regression lines, in essence. This is a slightly different depiction of that. It's looking at all-cause mortality. And one of the things that you see here on the far left in relatively wealthy neighborhoods is almost this anchoring of these points down here. And as you move right, you see these lines are starting to fan out. And in an ideal world, this would be kind of a flat line. And we think that this, in the low-income neighborhoods, has some meaning. We think that these communities are less equitable than these communities. And our goal in this work is to actually try to flatten those lines. About 5% of the explanation, particularly in the low-income neighborhoods, is homicide. I mean, there aren't that many homicides a year. I mean, you look at Alameda County, there are about 10,000 deaths a year. And in terms of homicides, there are probably about less than 120. So it just is not going to skew that line that much, unless, you know, the homicides are all in very, very young people, which they are not. It doesn't contribute that much. And I can show you the data analysis if you're interested. We have all of this data. Okay, so life expectancy. It's not just low-income communities. In 2005, the CDC predicted and actually challenged the Social Security Administration in the New England Journal of Medicine to say that, you know, your actuarial tables are wrong. You're not accounting for obesity and chronic disease. We predict that life expectancy is going to plateau very soon and then start to decline in the United States. And it wasn't that long thereafter when this study from the University of Washington showed that very phenomenon, particularly in the southeastern United States, particularly among women. Between 2000 and 2007, more than 80% of U.S. counties fell in standing against the average of the 10 nations with the best life expectancies in the world, known as the International Frontier. This was a study done at Stanford a couple of years ago looking at basically the same data using a slightly different measure other than life expectancy that allowed them to control for education and income. And when they controlled for education and income, they found that these differences, particularly in the southeastern United States, went away. That all of this life expectancy difference could be explained by so-called social determinants of health, two social determinants of health, income and education, that are entirely socially mediated variables. We have the ability to control those variables. We choose not to control those variables. We choose to essentially privilege certain populations with education and income and essentially leave the rest to their own luck. Just so that you know that this isn't just about diversity in the United States, when you look at just the health of white Americans, you see life expectancy for white Americans is around 78 years. This is a couple of years ago. This is changed. It's improved a little bit, not much. That's basically on par with the life expectancy of Chile, Costa Rica, Cuba, Slovenia, Kuwait. But it's shorter than Belgium, Denmark, Finland, Malta, Portugal, Spain, Sweden, UK, Korea, Austria, Cyprus, Germany, Greece, Ireland, Netherlands, Norway, New Zealand, Singapore, Canada, France, Iceland, Israel, Italy, Switzerland, Australia, and Japan. This is the life expectancy of white Americans. So as a whole, life expectancy in the United States is not very good, particularly for our wealth. 26 countries have longer life expectancies than white Americans. I'm going to skip through the infant mortality, but it's a similar picture. White infant mortality in the United States is actually substantially worse than a whole host of countries. When you compare chronic disease levels in the United States, again, just looking at white Americans, you find that wealthy white Americans have chronic disease rates, at least in terms of hypertension and diabetes, that are about the same as low-income Britons. This was a study done, I'll spare you the details. This was a study done in JAMA, and the conclusions were white Americans are much sicker than white Britons. Differences in socioeconomic groups between the two countries were so great that those in the top education and income levels in the United States had similar rates of diabetes and heart disease as those in the bottom education and income levels in England. We're not healthy in this country. I mean, we're not even close to healthy. Okay, so despite our wealth, the US is unhealthier across the board than our peers. There's evidence that flattening the social gradient, that's the regression line that I showed you, improves the health of all. I can talk a little bit more about that for any of the nerds in the room that really want to see the data. When you do international comparisons, the flatter that regression line is, essentially the better overall life expectancy you see in those countries. And those countries that have actually the least inequality of income have the greatest life expectancy. So there's something in that we need to understand. And the question is, can we develop focused upstream interventions, policies, and practices that may offer some promise? This was a study that came out about a year ago from the Institute of Medicine that looked at the US health compared to 17 peer countries. And I love the conclusions of this study because it was like they were like shocked when they saw the data. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The U.S. health disadvantage cannot be fully explained by the health disparities that exist among people who are uninsured and poor, as important as these issues are. Several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. So it's across the board. And the question for us is, does our approach, which is largely medical care, make sense? Given how much money we spend on it and how after the fact most medical care is, and I like to make this clear, medical care matters. It matters a lot. It's just, while it's necessary, it may not be sufficient. And I like to tell people that if you walk into a community like I did in East Baltimore, and if you see fires burning, what's the first thing that you do? See, put out the fires. And then you go to the local pub, you drink a Budweiser, you high-five your buddies, you go to sleep, you wake up the next day, you come back into the community, and there are fires burning in exactly the same places. Well, what do you do then? Well, you put them out again. But on the third day, when you come back and you see fires burning in the same places, you start thinking to yourself, as you're putting out the fires, how can I prevent these fires? And that's what this work is about, is trying to figure out how you continue to put out fires, which is largely medical care, but how do you prevent these fires from reoccurring day in, day out in the same places? Because we're smarter than this. We have better critical thinking skills than this, but our healthcare system design doesn't reflect those critical thinking skills. We're still acting as if we're walking to community every day and say, oh my God, there's fires, put it out. And the next day it's, oh my God, there's fires, put it out. So that's what we're trying to understand. What is the practice that tries to prevent those fires? Well, we know that living in a low-income neighborhood somehow translates into poor health. And there's always somebody at the end of one of these presentations who comes up and says, you know, my grandmother grew up in the barrios and, you know, dodged bullets every day on the way to school and, you know, only had one shoe and, you know, eyeglasses with half a lens. And she worked her way out of that. Now she's the CEO of Xerox. And if she can do it, anybody can do it. You know, I question the sort of the critical thinking behind that anecdote. However, it's true. There are people that can beat the odds in very low income communities in very difficult settings. It's hard to do, and they are superheroes. And our goal isn't to actually have people beat the odds. Our goal is to actually change the odds. We want more people, we want most people to be able to do well. And we set the odds through policy. So the question is, how do we change those odds? When you live in a low-income community, it's not just that you're a bad person behaving badly. There are stressors in low-income communities that manifest themselves in inadequate transportation, long commutes, poor and unaffordable and unhealthy housing, being socially isolated, not speaking the language perhaps of the community, having high demand, low control jobs, lacking access to basic amenities like grocery stores and parks, being worried about crime, being worried about your children's ability to navigate their route to school. That creates stress. I don't have to tell you how stress operates. It stimulates the hypothalamus, which stimulates the pituitary gland, which stimulates the adrenal glands, which releases a cascade of hormones, amongst which is cortisol. And we know that we need that in the acute setting, in the blue, in an acute stressful period. You need to have these essentially hormone cascades to stimulate cardiac output, to increase available glucose, to enhance your immune functions, to essentially manage your fight or flight, stimulate growth of neurons in your hippocampus and your prefrontal cortex. That's in the acute phase, which is good. It's life protective. But in the chronic phase, when you're constantly stimulating that HPA axis, it has completely different impacts on your physiology. It causes almost the opposite. It causes hypertension, cardiovascular disease. It causes glucose intolerance and insulin resistance. It actually increases your inflammatory system, decreases your immune response, and causes atrophy and death of neurons in the hippocampus and the prefrontal cortex. So we've got a number of people who are living in these stress incubators in this country as a result, and East Baltimore is a prime example of it, but we have them all over California, that are through no fault of their own. They didn't create those communities. They didn't essentially strip them of resources. Those were policy decisions or the absence of affirmative policy in the face of need that were made in political processes. And the only way to actually improve that is to engage people in those political processes so that they can more effectively advocate for equitable outcomes. And so to say that health is not political is to say that there's no way you can change these conditions. And I think that would be highly unfortunate and wrong. And for those of us who care about eliminating health disparities, you can't just focus on the clinical setting. You actually have to look at the context that creates those disparities. So we're arguing that if you look at disparities, you're only looking at the tip of the iceberg. And that leads to this framework. And the framework is a simple one. It's not a model. There are people who are model aficionados who say, you know, that arrow should be going this way, and then there should be another one coming that way, and it should be thicker than that one. This is just a framework to sort of spread out the opportunity spectrum for intervention. Where can we intervene to try to actually change the flow of this inequity-producing disparity? And the typical medical model is you look at premature death, infant mortality, shortened life expectancies, and you think, well, that's driven by higher burdens of disease and injury that's in part influenced by genetics, it's in part influenced by access to health care, and it's also driven by risk behaviors and risk factors, smoking, not eating appropriately, not exercising, not ducking appropriately when bullets are flying. All of these things drive injury, which drive death. And where we try to intervene is around individual health knowledge and 15-minute interventions in a cubicle in a clinical setting. And that's largely the medical model. I mean, I'm being rather ingenerous with the medical model. I mean, it's bigger than this, but this is the core. This is what I spent $100,000. Believe me, I know that's shocking to you. It cost $100,000 to go to Hopkins Medical School in the 1980s. I know that costs you that every minute here now. But that's what I spent $100,000 learning at Johns Hopkins Medical School, and I came away dissatisfied thinking that there's a bigger story that existed outside of the walls of the medical school, and that's the socio-ecological context. Whereas the medical model deals with sick individuals, the socio-ecological context deals with sick communities and sick society. And it talks about social inequities that manifest themselves in essentially neighborhood conditions, residential segregation, some workplace conditions that are highly stressful, buffered by family and culture. Immigrants tend to actually do better in these settings in the first generation than Native Americans, native-born Americans. Institutions and policies set these conditions. There are practices and decisions that create these conditions that are driven by corporations, by government, by a whole host of other institutions. And those institutions are disproportionately driven by a narrative. And the narrative is historically in this country, you don't have to look very far to find it. And just open up the Constitution, it's in there, and I'm 3/5 of a person. So, historically, the narrative has been that some people matter more than others. And some people are more deserving of resources than others. And therefore, policies should reflect that. And those policies create conditions and environmental contexts that essentially deprive certain people of critical health protective resources, knowing full well that they need them, but recognizing that they're just not as valuable as other people. And so we have a set of isms based on race, class, gender, immigration status, national origin, sexual orientation, disability, you name it. That is the historical narrative in this country. And so we're arguing that this narrative drives these policies that create these conditions, that create this downward cascade of disease, all of which is preventable. We have interventions in these areas. We need to think about what are the interventions in these areas. This is the world of health disparities. This is the world of health inequities. You can take health out of the equation and just talk about inequities producing disparities. Or for your simple-minded country bumpkin like myself, you talk about conditions producing consequences. And we spend a lot of time and money, about $2.8 trillion, on consequence management, or I like to refer to it as damage control. And the question is, what can we do in this setting that's actually going to mitigate this? This is where we're putting out the fires, and doing a pretty good job of it. You can actually substitute these downstream outcomes with educational outcomes, school absence leading to grade failure, leading to dropout. We know that that is actually associated with a very low health trajectory in life if you drop out of high school. So let's talk a little bit less about downstream and let's talk about upstream. At the California Endowment, we're trying to figure out what is the practice around these neighborhoods and these conditions in workplaces that create this sort of stress on individuals that produce and promote disease. We also want to look at the policies that create those conditions and think about the health consequences of non-health policies and help in the policy-making realm to create policies that have better health consequences. We think that that's insufficient. We also have to look at the narrative of health. What's the story we tell ourselves about what produces health? And you don't have to go very far in this to see what our narrative is. Our narrative is basically access to health care. Just look at the Affordable Care Act debate, the Obamacare conversations, and deserving people versus undeserving people. Bad behaviors, people who smoke, drink, don't exercise individual responsibility, and those that do. Don't get me wrong, individual responsibility matters, and it matters a lot. It's just not the only thing. There's also a social responsibility. There's a context in which people are making decisions, and we have control over that And we should be intervening in that, not just waiting for this downstream cascade to occur. I talked to you about power earlier. In this society, low-income people have less power than others, substantially less power. And the society is actually predicated on that fact. So in order to change this status quo, we actually have to change the power dynamics in communities. We have to build social, political, and economic power in a critical mass of low-income people living in these conditions, because only they can adequately and sustainably participate in changing the level at which people participate in political processes locally. And again, when I say political processes, I'm not talking about going up to Congress and testifying. I'm talking about showing up at the school board to talk about the kinds of food that is being served to children in school lunches. Participating in those processes has profound health impacts. Okay, very simply, the medical model says bad behaviors produces a burden of disease, which produces premature death. The socio-ecological model says that there's a set of biased beliefs historically, and there's a legacy of those beliefs today in present practice, and there's some present practice. You just look at, the battle over gay marriage, or, some of the immigration debates, how they play themselves out in policy. And you see that there's still a predominant narrative in this country that some people deserve and some people do not. Those biased beliefs drive a set of policies and practices that produces communities that are on life support. Now, we have interventions to try to prevent death. We call them emergency rooms. We have interventions to try to prevent disease. We call them clinics and clinical settings. We have interventions to try to change people's behaviors. We call that health education. We don't, for the most part, have interventions to try to address communities that are on life support. We have won, and others have won. As I said, I was at the White House yesterday, and Promise Neighborhoods is an effort to do that too, is to try to focus resources in a collaborative, coordinated way to try to optimize the way that those resources and the way that the systems work to potentiate opportunity, particularly for low-income people. We think that that's insufficient. You also have to look at the policies that create those conditions, and as I said before, look at the health impact of non-health policies. We think that that's insufficient. You also have to change the narrative around health. Health is not just about what you do and what your doctor can offer you. It's also about the opportunity structures that you have. It's about the education that you get. It's about the kinds of conditions you have in your workplace. And if it's all of those things, and we're spending $2.8 trillion on it every year, we ought to be thinking about interventions in that socio-ecological space that will reduce the demand on the overtaxed healthcare delivery system. Okay, so what is it we're trying to do at the California Endowment? I have the privilege of working with Steve and many other just really committed people on an enterprise where basically we were given $1 billion. And the only condition on that $1 billion was that we had to spend it in California. We had to work in 14 low-income communities and try to improve the health status of low-income people in those communities without spending money on health care. That's the challenge. So we're trying to figure out on that model that I showed you, how do you invest on the upstream side of that? And we have, as I said, $1 billion to do it. Now, $1 billion is not a lot of money. It sounds like a lot of money. It's not a lot of money. You guys spend more than that every year, in clinical care right here. So it's some money. It's flexible money. And what we're trying to do is figure out how to leverage other resources to invest upstream. We call it building healthy communities. These are our 14 communities around the state. As you can see, we have one down in City Heights in San Diego. Our recognition is that it's human capital that matters here. It's not bricks and mortar. It's not new technology. It's investing in human beings, particularly in young people. Our goal, as I said earlier, is not to have people beat the odds, but it's to change the odds. Our focus is on 4 core systems. The health systems is critical, trying to move the health systems to the extent possible into a preventative posture where we're really optimizing the opportunities to prevent disease, using this incredible resource that we have in the clinical space to actually influence policy, changing the way that healthcare is considered, trying to develop patient-centered medical homes, trying to look at the actual clinical encounter in that 15-minute cubicle-based visit, and thinking about how do we actually try to modify that where it makes sense, to look at group visits, to look at using the patient as an asset to help other patients that are similarly situated. These are all critical things that we can do within the existing context that don't require radical reform. The human service systems, particularly the criminal justice system, we think is critical, trying to keep kids off of the school to prison pipeline, which is just a downward escalator to despair. Intervening in that process has turned out to be a much more effective strategy than we had even hoped, and I can talk about that later if people are interested. Looking at the school system, and then looking at the built environment, the physical, social, and economic environments that shape opportunities for people. The ability for people to go to a park, or to go to a grocery store, or to ride your bike, or to walk, or take the bus. All of these things are the product of essentially decisions that are made primarily locally, although there are some regional and statewide influences. And we have a coordinating table in the middle of all of these sites that we call the hub, which is, as I said earlier, is to bring the butcher, the baker, the candlestick maker, bring all of these various sectors together to focus on some common goals, like maybe improving the high school graduation rate in a community, or improving third grade reading, or improving participation in early childhood, high quality early childhood settings for young people, because we know that that pays off in the long term. And unfortunately, we haven't been able to bring people together around these things very successfully in many places, although there are exceptions that are great models for us. How are we doing this? We're building power, as I mentioned, organizing people. We're actually having community organizers go door to door in these communities and invite people to participate in actually setting priorities for their community. We're working on policy advocacy, looking at, for instance, things like, looking at a school campus. They have a gym, they may have some fields, and in the evenings, in the summers, on weekends, there's opportunity for community to actually use those facilities, to actually recreate in those facilities. And so this notion of joint use, to actually take school facilities and open them up to the community when the school's not using them, is one of the core strategies that we're using. I mentioned that, and this is something that, I'm a doctor, I'm an internist. And when I came to work for the California Endowment, one of the things that I was, I quickly realized I needed to learn a whole new set of things. One of which was how money works. And one of the rules of money is that money loves money. And so we were sitting around talking about this idea that, we have these communities where there are no grocery stores. And we knew that there had been some efforts, particularly in Pennsylvania, to create these things called food trusts. And so our money people started saying, we should just create a private fund. And the purpose of this fund will be to build grocery stores in low-income food deserts throughout California. And we were like, but why would people want to invest in that? And they said, trust us, money loves money. So we put $30 million into a fund and basically advertised this to the world. And within 18 months, we had $300 million to build grocery stores in low-income communities in California. And I would never have thought that that was possible. But money loves money. And the fact is that nobody wants to be the first one in. But if you're the first one in, everybody wants to be the second one in. Don't ask me to explain that. It's probably anybody who's studying psychology in the room, you could write a great thesis on this. Money loves money. So we have a $300 million fund to build grocery stores in low-income communities throughout the state of California. I said changing the narrative is important. When we worked with the Baltimore City Health Department to produce that map of life expectancy, it was front page news on the Baltimore Sun. I warned them that that would be the case because when we had done it in Alameda County, it became front page news in the San Francisco Chronicle. We looked at various different ways of looking at this data. It became a media series in the East Bay newspapers that actually won the Edgar Allan Poe Award at the White House Correspondents Association dinner, and those reporters now love me. One's writing a book about building healthy communities because they got to meet Obama and got feted at the White House Correspondents Association dinner. They wrote this series that just followed people's lives, these parallel lives, and showed how different people have access to a completely different set of opportunity structures depending on their address. This is the White House Correspondents Association. Some of you hopefully have seen Unnatural Causes. I saw it was one of the lectures that was done here in this series. It's a great video series that is very accessible. It's produced for lay people, and it actually just chronicles all of these forces that shape people's health outcomes. This was a series that HBO did called The Weight of the Nation that we were lucky enough to be involved with. It also talked about the obesity epidemic and how the clinical approach is insufficient, although necessary, to try to actually reverse the tide of this epidemic. But we have to look at the socio-ecological model and start intervening in a meaningful way if we want to change that epidemic. We've also advertised around the country and certainly around the state the data. This is a series of posters and billboards that basically shows how your zip code is more important than anything else in terms of shaping your life expectancy. And these are different zip codes in California showing life expectancy differences and high school graduation differences. This is in the new terminal of the Sacramento airport where all the legislators fly through. We know that they see this because they call and they want to know why we're reducing property values in their districts. This was the American Public Health Association meeting the year before last. This is the Metreon building in San Francisco. We literally festooned the building with these billboards, and believe me, that got attention. We've created these campaigns. We call them Health Happens Here. We think that the critical avenues for doing this work is in neighborhoods, looking at land use and the built environment and some of the systems that impact, how young people spend their time outside of school. We think that health happens also in schools. We have to invest heavily in schools, and this is where healthcare institutions really matter. The partnering of healthcare institutions with educational institutions is critical, not just for mentorship. I know there's a FACES program here, which is great, but also in looking at things like physical activity, looking at things like the social and emotional health of young people in these school systems is critical, and you are the experts in this. And we also think that health happens with prevention in the school system. I'm concluding now with the secret sauce of doing this work. And this is going to, for many of you, this will look a little bit foreign. And I think as you spend more time with this issue, if you do, which hopefully you will, you'll recognize it as being necessary. I mentioned that power is important. We have sort of systematically disempowered certain populations in this country because we think that they're not as valuable as other populations. I mean, that's the truth. We've just said gay people shouldn't be able to get married because they're gay, and they're not deserving of that recognition in society. Immigrants really should not be allowed to have access to some of the benefits of society like Medi-Cal because they're immigrants and they're somehow less deserving than other Americans. We know what we've said about African Americans and Latinos and Chinese and, in laws that prevented people from marrying, prevented people from owning property, preventing people from doing a whole host of things. Granted, that was historical, but much of the segregation and the legacy of that we're still dealing with today. We're dealing with it today, and there were policies post some of the more overt practices that existed well into the 1970s and 80s that created the conditions that we're dealing with today. So we have to build social, political, and economic power amongst residents. We also think that we have to bring all of these various sectors together, health, land use, and a whole host of other sectors, to try to find common purpose. We have to build new leaders, particularly youth leaders. They're critical. We have to leverage private capital. That's what the example I gave you about the grocery store fund is essentially trying to bring private capital to bear on these social issues. We have to change the narrative. We think that that's the recipe for building healthy communities. In conclusion, it's really about building power, it's about changing policy, and it's about creating a new narrative. We need your help in this work. We need your brains. We need your credibility. Physicians, particularly pediatricians, have an enormous amount of credibility in the policy space. And we actually fund a program at the California Medical Association to train and enlist physicians to be public spokespeople for these socio-ecological investments or the social determinants of health as being a critical factor in shaping the outcomes that we're dealing with in the clinical setting. I came at this work after years of being frustrated trying to solve this with a stethoscope and a black bag. I mean, I ultimately recognized that I was being asked to treat social ills with pills, and I don't think that that's either effective or reflective of good critical thinking. And I think that many of you have felt that frustration, and we invite you to join us and participate. We need you. Thank you very much.
Are you aware of any regions, urban regions, that did not show any of these disparities by zip code?
Yes, thanks for that question,
and
actually.
what is the analysis of how that comes about?
So the longer version of this talk goes into sort of stratifying different populations within these communities. And what you find, and it's what we found in Alameda County, which was fascinating, it ended up being one of the subjects of unnatural causes, one of the parts of unnatural causes that's focused just on this phenomenon, is that low income, particularly Latino immigrants, but it's true of all immigrants, don't reflect these same patterns. In fact, the healthiest people, longest living people in Alameda County are low income Latino immigrants. They live longer than wealthy white Alameda County residents. And that phenomenon is sometimes referred to as the immigrant health paradox. We were pointing this out in the 90s. CDC finally confirmed it about 3 years ago. It's not just Latinos, it's just in California we have a more homogeneous Latino population that we can study in that way. It's true of Asians. In fact, it's true of every immigrant group. They live longer than their Native American-born counterparts, including African immigrants, European immigrants. And then within one generation, they generally start to model the health status of the American population. So we like to say that America is not good for your health. People say acculturate, they actually get sicker and they die earlier. So when you look at communities around the state of California where you have very low incomes but high life expectancy, they're disproportionately communities where there are high levels of relatively new immigrants. And in California, typically Latino immigrants. And we think that there's something to be learned from that. We think that immigrants, A, come here to work, so they're very focused, they're very hopeful. 2, they tend to have very tight social networks, which are very important to reduce stress and to buffer some of the hostility that they might see around them. 3, they tend to have more traditional diets. They tend to eat healthier foods. And as they acculturate, all of these things start to essentially dissipate. And they become much more subject to racism and exclusion and all of the stressors that sort of drive these phenomena in low-income communities.